Welcome to this evening's webinar with myself. My name is Mike, and we're here with Dan Lawrence as well from Physio channel and Rock Tape. We are going to have a chat about Cauda Equina Syndrome this evening. Hey Sue, and Sue was here on the course as well. Yeah, recognizing these names. So we're going to have a chat about Cauda Equina Syndrome. So it's probably one of the most important topics. We were going to do a broad kind of topic about back pain, but we decided to be a bit more specific and focus on Cauda Equina because we would have been here. We would have been here all week, yeah. I think. Yeah. So we're going to just narrow it down and focus on this. So that there's been some really good papers come out over the last couple of years guiding our assessments. So we thought it was timely to do something like this. Dan, do you want to introduce yourself?
Yes. Hi, I'm Dan. I'm the one on the screen with Rock Tape written on my top. And we often get questions about whether these sessions are recorded, and hopefully you know that they are recorded, but should you wish to share them or let other people know, usually a couple of days afterwards I upload them onto the Physio channel on YouTube, where there's a lot of other educational videos as well available for free. So that's the Physio channel on YouTube, and that's a great place to look for some resources. I'm a physiotherapist, an educator, and a writer as well. So some of you may have seen me at events. I may have seen you. I'm not really sure where I'm going with this, but that's my introduction for now, Mike. Thank you.
Perfect. Great. And if you haven't met me before, I'm usually with Dan at the events as well. I'm an osteopath. I'm from a sports therapy and fitness background. And I've been working with the Rock Tape team for a couple of years now, delivering all the courses. Finished a live stream of the taping course last week, which went down really well. I hope it went down really well. We've got a few of the students in the chat room there, and we've got another. We mentioned it last week. We've got a pods course that was in June, or that is in June, but that's now full. So we're going to put on another date. So we'll let you know about those as well. So without further ado, let's get going. So we're going to have a chat. Thank you, Wendy. The checks in the post. Thanks.
You're giving out a lot of checks. You're giving out a lot of checks, Mike.
So we're going to have a chat about Cauda Equina Syndrome today. I'm going to go over things that you were covering, your subjective history, and then Dan is going to have a bit more of a chat about the assessment side of things. But they go well. Both Dan and I are pretty much going to cross over with the things we're going to talk about. But just wanted to give a little bit of an anatomy recap. So we're going to teach this like you've no idea what Cauda Equina is. So no apologies if we're teaching you to suck eggs. But this is the Cauda Equina. So that this area, hopefully if the video shows, here we go. So this area around here, that bit there is called the conus. So that's the end of your spinal cord. And then the cord then is stretched into long filaments, which are your lumbar and sacral nerves. And these they're like, Cauda Equina means horse's tail. So it looks like a horse's tail. And you can see the nerve filaments going all the way down into the sacrum. Oh, it's gone there. Never mind. Right. So, well, there you go. Very brief video. So that's a bit of an anatomy recap. So you got the conus, which is at the level of L1, L2, and then the nerves are then stretched all the way down from that region all the way down to the bottom of the sacrum. So it's that region that we're focused on. But usually Cauda Equina affects the lower lumbars and upper sacral region. Okay, so that's in particular where we are. So did a bit of research. Where a lot of this comes from a study by a chap called Todd, and I've popped the reference on the next slide or two along. And if anybody wants it, let me know, and I can post you a link. But the epidemiology of who gets it, the incident is variable dependent on the etiology, which is the way that they've developed it. Okay, and the prevalence is estimated between 1 and 3 per, that should be 100,000 of the population. And this was taught to me when I very first learned as something that would be in a once in a career kind of event. And I've already had mine, so it would be nice never to have them again. But I think it is a lot more prevalent than we were originally taught. I would say. I think Dan's got some stories to share as well. So Cauda Equina Syndrome is reported in approximately 0.04% of all patients presented with lower back pain, and 2% of cases with herniated lumbar discs. Okay, so it's a narrowing of the spinal canal or acquired spinal stenosis arising from a combination of degenerative changes and then posterior joint changes. So we're basically narrowing the space available for the nerves in that Cauda Equina. And some people have said they've had a few clients with Cauda Equina already. I'm sure we've got quite a few stories to share amongst all the people that are here. So how does it occur? There are various different ways that you can get it. So herniation of a lumbar disc is the most common cause, and usually that L4, L5, L5S1 level. It can be from tumors, so metastatic spread or lymphomas, spinal tumors. It can be from a trauma. Yeah, it looks like Emma her sister has had it post accident. Okay, so the trauma may be one of the reasons why. Infection risk could be congenital because of the changes in the room in the spinal canal. A spondylolisthesis, which is a slippage of the vertebra, usually L5S1 region. Late stage ankylosing spondylitis, which is a change in the ligamentous structure of the spine. It starts to harden, and if you've been doing our clinical reasoning sessions, I've been doing Monday, Wednesday, Fridays. We've had AS as a potential differential on a few of the clinical reasoning sessions we've done. It could also be from a post-operative hematoma, so basically a collection of blood basically in that region and putting pressure on the spinal cord. So there are various different reasons why people get it, and it's important to know that it's not just one thing, and you'll pick up clues in the case history about why someone may have it. Okay, so I was having a look at the NICE guidelines, and there aren't really any specific definitions for Cauda Equina. So this is one that a chap called Chris Mercer recommends looking at. So it's from the British Association of Spinal Surgeons, and it's acute back pain and or leg pain with a suggested disturbance of the bladder or bowel and or saddle sensory disturbance. Okay, so we've got quite a few ands and ors in there. So most of these patients though will not have Cauda Equina syndrome, but in the absence of reliable predictive signs and symptoms, there should be a low threshold for investigation. Okay, so it's really important that we try to catch these people early. Matthias, wow. Now Matthias has just popped up on the chat box. I met him in Belgium. Taught him in Belgium. Good to see you, Matthias. Right then, so this is from the Todd study. So this is guidelines for Cauda Equina syndrome, and this is a real is a kind of look at the whole practice of how we manage Cauda Equina syndrome and whether we can categorize people into certain categories, because what they found is that when it's picked up by us in the clinic room, it's often too late. Okay, so what we need to do is we need to spot signs of Cauda Equina really early so that we can get these people investigated really quickly. Okay, so and that this isn't these aren't the NICE guidelines. These are just some suggestions from Todd about shaping the guidelines. Okay, so just to let you know. So you can have CESS, which is when Cauda Equina Syndrome is suspected or suspicious. And Dan will elaborate on this a little bit more, but it's a bilateral radiculopathy. So basically symptoms down both legs. Problems with the or sphincteric problems, so around the anal sphincter, and subjective perineal sensory changes. So that's in the area that you sit on, basically on the bike, so in between your genitals and the anus. So around that area you get sensory changes. And it's important that we question these things in the subjective history, because if we can pick up on these things early, then we may be able to save someone when you get down the line. So CESR, where you have Cauda Equina Syndrome retention, this is where you have real bad problems with the bowel, bladder, sexual function, and it's past the point of no return. Okay, so we want to be able to try and highlight these changes in bowel, bladder, sexual function really quickly if they're associated with the other symptoms as well, and get people investigated before it's too late. Okay, so really important. And I'll show you something that you can use with patients in clinic. So part of the study by Todd looked at and these were the things that I was taught to ask questions about Cauda Equina. And that's towards the right hand side of the arrow. And unfortunately, when they're at that right hand side, they've gone so far that that rather than being a red flag, he's called it a white flag, because at that point you should wave the right flag, and because you've kind of given up on them, because they've got urinary retention or incontinence, fecal incontinence, and perineal anesthesia. So if they have those kind of issues, then they have progressed possibly quite far down the line, and it may be the point of no return. Okay, so we want to catch people earlier, so towards the left of the arrow, where they have this bilateral radiculopathy and then progressive neurological deficits in the legs, and something that Dan will talk about in a sec. So we want to try and question these things really early with anybody with back pain, to see whether they've got any of these other associated symptoms. And one of the things that that's come out of a lot of discussion with patients is that when we were asking questions about bowel or bladder changes, they didn't really understand the question. Okay, and they didn't really understand the importance of the question. So it's really important that we get that across, and the way that we frame it, and we'll talk about that now. So it could be that you're a bit embarrassed about asking. Okay, so and one of the questions is, have you got any changes in your bowel or bladder habits? So what patients would often think you meant is, did you have you had a bit of constipation or something like that? Yeah, so we need to nail down the questions so that they're very, very specific, and I'll show you what they could be on the next slide. Also changes in sexual function as well. So something that we don't, it depends on the level of your training, but usually if you haven't done a degree program, you don't really get taught to ask these questions about sexual function. And also, if you're a new graduate, sort of 21, 22, you might feel a bit funny about asking an older patient about these kind of issues. So it's something that we need to look at ourselves about and make sure that we are comfortable in asking these questions and how we frame them. Okay, but also the pain that people are in may mean that the patient can't take in the question, and they don't really understand, well, why the heck are you asking me about this when I'm in absolute agony? Yeah, and they don't see the relevance of the question. So it's important that you frame it and say, look, that this is the reason why we have to ask it, because of these potential issues. Okay, this was something that Chris Mercer put together. That was on a podcast with Jack Chew, so I decided to put it together for my clinic. So we have a safety net system. So if you think that if someone's got radicular symptoms, and it may not be bilaterally as well, it may just be unilaterally, but they and you think, right, they could be a candidate for Cauda Equina, but they're not really showing the full signs of it, then you can give them one of these cards or something similar. And these have got very, very specific questions in that are there should be no ambiguity. Okay, so if we just have a look at some of these, so increasing difficulty when you try to stop or control your flow of urine, you know that's way more specific than have you got any problems with your bladder. Yeah, so we're asking very specific questions. Have you had any change in the ability to achieve an erection or ejaculate? You might feel really strange asking that question to someone, but but you need to frame it in the right way, and it's really important that we ask that question if they have any of the symptoms that we talked about earlier. So this safety netting card is important if symptoms progress. So if they get worse, rather than come to you, you can tell your patient, look, with this card, if you got any of these symptoms, then you take this card to A&E and you tell them your symptoms and say that you've already been to see me, and that they should immediately scan that person. Okay, so so we can get that early diagnosis and then early treatment and early procedure. Cool. So that's an introduction to it. I'll hand over to Dan. Over to you.
Great. Thanks, Mike.
Are you there, mate?
I am. Can you hear me? Can you hear me okay?
Yep, can hear you. Yep.
Brilliant. Mike,
yep,
if you
good.
keep your video on, then I know you're still there, because otherwise
yep.
I reckon you just go off and get a cup of tea and leave me to it.
Get a cup of tea, yeah.
Yeah. So at least pretend to listen. Otherwise I get worried I'm talking and then nobody's there. You know, like when you're speaking on the phone and someone says, sorry, what did you say? I was like, well, when did it? Oh, about 5 minutes ago. You're like, oh, all of that important stuff.
Which bit have you missed?
Yeah, exactly. So when you were talking about the symptoms card, there's a really good one, and I've just put the link on the chat, which was developed largely for the NHS, and it's available to download in multiple languages. So Brilliant. That will immediately make people's life easier when it comes to putting what we're talking about tonight into practice, because there's a lot of information, and really you want to just do your best to detect this Cauda Equina issue if it arises, or to detect the symptoms, and that can be quite complex and overwhelming for people. So to avoid any of that, you don't even need to remember anything we've talked about tonight. You can just download that card, use that when you're assessing, but also give it to patients as a safety net, which I'll talk about in a moment. So when it comes to serious pathology of the spine, of which we're focusing on one thing tonight, but Mike's already mentioned other things that can go wrong with the spine. When it comes to serious pathology, it does get missed by the best of clinicians, by the best of doctors as well. It does get missed. And I was speaking to a doctor a while back, and he said that mistakes do happen. You know, when you're seeing multiple patients, multiple conditions, you are going to have things that you miss. You're going to make errors. You may, misdiagnose or miss a kind of key symptom or something like that. So things do get missed. And even if you're a Cauda Equina expert, then you could still potentially miss a Cauda Equina, not because you've been negligent, but because it's so difficult to define. And that's why Mike mentioned that there should be a very low threshold for further investigation, for onward referral, a low threshold for emergency scanning. And what that means is that if you just have an intuitive suspicion, that's enough. That's enough to to refer on and to get some timely advice. And I'll talk a bit more about that in a moment, because timing is key here. So the low threshold means that if there is a suspicion, then refer on. It should be, what we're talking about tonight, a core part of the initial questioning. So you can use that Cauda Equina card. You can use the symptoms that we're talking about tonight. That should be a key part of their patient's questioning. A patient comes to us with back pain. They're going to be very focused on the pain and the bit that hurts. And they might, as Mike's already alluded to, start to get a little bit confused as to why we're asking about like erections and I don't know, anal tone and you know, asking these kind of odd questions. And that's something that Mike's already tackled, but it should be a core part of our assessment. When a patient comes to me with severe back pain, I want to help them, but I'm less interested in the pain that they've got. I'm going to deal with that in a moment. I'm more interested, or more importantly, need to just work out whether they have any signs of Cauda Equina syndrome. And as Mike said, it's very rare, but it's at the very apex of the red flag questions. It's one of the things that you want to try and rule out as quickly as possible, or as soon as possible. So it's not a question that I tend to leave to the end of an assessment, but it really doesn't matter as long as it gets asked, and as long as there's some time spent on it, and as long as the questions are framed correctly as well, which Mike has mentioned. So raising awareness as well. It's about asking questions, but it's also about this idea of safety netting. Your safety net, guys, can be simply giving people that downloadable card from the link that I've shown you. And you can find other versions, such as the one that Mike showed you, that's available. That's a safety net, because you say to the patient, look, these symptoms are very rare, but if they do occur, you need to address them in a timely fashion. Present yourself to an emergency department, tell them you've got this, and these symptoms that are written down for you, and that's safety netting. Because if they have symptoms and they wait a week to come and see you, or even a day to come and see you, that chunk of time can be very, very significant. And it can mean the difference between them having full treatment and having no problems, to potentially them having being potentially too late, or having treatment and not being able to reverse the potential damage to the nerves. So time is key here. It's very rare. It's important to highlight that. It's very rare. But if it is going to be there, it's not going to be that easy to pick out, and it needs to be dealt with quickly. So that's the topics of my discussion here. Also, another thing is to reassess. You're going to assess this in the first session, but I would always advise reassessing, particularly for, you know, asking your kind of key Cauda Equina questions on subsequent sessions, whether that's on the phone or, you know, in person as well. So reassess, don't just leave it all down to one thing. And that's because symptoms, serious pathologies and symptoms of CES can come and go, can wax and wane, and can be a little bit up and down rather than just progressing. They can sometimes be grumbly or lingering as well. And I've heard of one case of a patient who was clearly told, bearing in mind here, you can't force people, guys, but this guy was clearly told by his doctor to go to A&E with this note because he needs an emergency MRI scan. He did go after his week's holiday. And he was okay. He was okay. All right. And so he got away with it, but that was a very risky holiday, if you ask me. So that comes to this point. If he had gone and missed his holiday, I should imagine he would be quite upset about that. And I had a patient once who was a bit upset. Just, you know, they weren't, you know, really cross with me or anything, but they came to me with back pain privately. They wanted some treatment, and they had some of these Cauda Equina type symptoms, bladder and bowel disturbances of some description. I think, I can't quite recall. I got my colleague in, and they had a look, and they thought that it probably wasn't Cauda Equina, but they did have some of these symptoms, and they had said some things. So again, you know, low threshold for a referral. So they were given a letter to explain the symptoms, and they were sent to A&E so they could, you know, get an emergency MRI scan if deemed appropriate. But they had to be sent straight away. Otherwise, it would be sort of almost pointless saying, well, come back next week and see how you are. That's not what we do with Cauda Equina. And they were absolutely fine. So they were a little bit cross that they hadn't received treatment. and they are a little bit cross that they've been sent to A&E. Nobody likes going to A&E, and they'd been obviously hanging around and had some other checks and stuff like that. But that's the sort of thing you have to do, because a lot of the time, people like myself and Mike and I will talk a lot about reassuring patients. And last week we talked about placebos and not wishing to put in place nocebos and to scare patients. And you can't but help but realize that sometimes talking about Cauda Equina syndrome with patients is going to make them feel a little bit afraid and is going to concern them. So the trouble is, you have to do that, and you have to send patients off with symptoms, because we're not really talking about pain here. They can just have sensation losses, and they may not have Cauda Equina, but they have the symptoms. So you have to put the patient's health and welfare first, even though it may slightly upset your wish to put the patient at ease, which is what we often try to do in practice. So that's one of the conflicts that I find that exists, is doing what's right by the patient's health and not necessarily doing something that pleases the patient. And there's just that conflict there. But of course, the priority is doing what's right, and that's following the guidelines, which is what we're talking about tonight. Mike, I just wondered if you had anything to add to that, because that's something that I've always thought about, is that difficulty in sharing that information with patients.
Yeah, I think it's like you said before, it's all about framing it. And because I always but anybody with back pain, I obviously ask these kind of questions, because they don't immediately associate the back pain with changes elsewhere in their body. So I say, look, I'm going to ask you some questions now which may not seem related to your pain in your back, but the nerves in your back supply this area of your body. So I need to ask these questions about sensory loss in the genitals, or strange sensations if you're wiping yourself after you've been to the toilet. And I always frame it beforehand like that, and just so they know that, rather than just asking some silly sort of willy-nilly questions, I'm asking something that's quite specific to that region, and that's why I'm asking it. So it's but yeah, I think like you said, we spend our lives trying to play down the degenerative changes, causing you problems, but this is one where you can't do that. It's
absolutely. So you mentioned earlier about the different causes, and from looking at the information out there, for younger patients, it tends to be the most likely cause is a central disc protrusion. Of course, there's many other potential causes, but that's the most common for younger patients. But for older patients, it's spinal stenosis, which can affect quite a large proportion of older patients. It tends to be the older the patient group, the more likely they are to have an element of spinal stenosis. And of course, most spinal stenosis exists without any significant symptoms. A proportion of them have symptoms, and then a very small proportion might have enough of a narrowing to cause the Cauda Equina compression. But in these older populations, we also have often quite bladder issues are often quite common in older age groups, more so in women than men, but still in men as well, as is sexual dysfunction, which becomes more apparent with older age as well. So we've just said about bladder, loss of bladder control, and we've just said about sexual dysfunction, but now there's a patient group which could also have these as a result of other factors and not Cauda Equina syndrome. But we can't just say, oh, well, it's, because you're, in the older age group, that's why you've got bladder problems. Therefore, we'll discount that as a potential cause of Cauda Equina syndrome. So that's one of the things that, as Mike mentioned right at the beginning, is that it's really tricky to have some definitive signs and symptoms for this condition. And patients may have other co-founding factors, other comorbidities that can muddy the water really in terms of the diagnosis.
It's a good question by Peter there, Dan. Sorry to
Yes.
to butt in, but it sounds like legitimate questions from an osteo or physio, but from a soft tissue therapist, a bit trickier. That's a really good point, because I think it depends on the level of soft tissue course that you've done, but usually you will hear about Cauda Equina and it's the cardinal sign of pain down both legs. That's what you're usually told to screen for, but and the bowel bladder changes, but not the changes in sexual function, and maybe not questioning those things in a bit more detail. What kind of things, because obviously I've got sports therapists working with me here. Have you put anything in place, or have you seen anything to help sports therapists out with this kind of questioning? So
Yeah, absolutely. Well, the link to the card that I posted there is a very credible information source. It's been developed by a few different organizations and used by the NHS. So if you could divert the patient's attention to that document, it asks the questions for you, so you could even just get the patient to read the information on there, and that would be a way of getting that information across, and it's obviously framed in a very legitimate way with being linked to the NHS. And if then something does arise from that, then once again the literature is available to credibly show the patient, look, this is your situation, you've got these symptoms, and these are the recommendations and the guidelines. So this is what you should do. It's always down to the patient, and they might decide not to do what you suggest. But then if you're in your notes, if you said presented them with the Cauda Equina symptoms, and they had a couple of symptoms, and I highlighted that the guidelines said they should do this, and then that's it. What the patient then does is somewhat out of our control. I wouldn't treat somebody who had clear signs and symptoms. I think I don't know if you'd agree with that, Mike.
Yeah, definitely.
I think by not treating them, I think you would. I'm not saying you'd make it worse by treating them, but I think by not treating them, you're saying to them that this needs serious attention, rather than, okay, I'll get on with the treatment and see how we go. So I think that does give them a serious message that it needs looking at.
Yeah. Have you ever had to send anyone from your clinic straight to A&E?
Yeah.
It's not nice, is it?
No, that was the particular one from a private clinic that I had to send. They didn't like it. I've sent a few to the GP next door. And I think 2 of them have gone on to have scans. But and that's one of the things I wanted to mention tonight, is that of the people who are referred with symptoms, only a very small percentage, I think I've wrote it down somewhere, but I'll just guess, and I'll correct myself if I'm wrong, but I think it's 10%. Pretty confident. So of 10 people that get sent with signs and symptoms, when they do an MRI scan, only 1 of those 10 will actually have Cauda Equina compression. So it's rare in the first instance, but then it's also rare again even after you've been referred with the symptoms, which is good news. So of the people I can recall, none of them actually had Cauda Equina compression. They just had the symptoms. However, I have worked with a patient who was on the other side of this and had unfortunately had some long-term sensation loss and loss of control around that area due to Cauda Equina, which wasn't picked up. And when he recalled his story to me, it was really in line with what we've been discussing tonight. And what we are discussing is that it wasn't a clear set of symptoms. There was this sort of like myriad of hit symptoms that came and went a bit, but it wasn't like, oh gosh, that was definitely it. It was like, oh right, that sounds really unclear, and I'm not surprised that wasn't detected as quickly as it should have been. And that's one of the situations. So moving on. Serious pathology of different types can be sneaky, so there can be a lot of false negatives. As I said before, it waxes and wanes, so sometimes symptoms can be a bit better, symptoms fluctuate. And also we've got a desire to reassure patients, but we can also be falsely reassured ourselves. So if we treat a patient and they feel a bit better, that's great. And we can then think that they're on the mend. Whereas what might have actually happened is that they are just experiencing a normal fluctuation in symptoms, or maybe some of the placebo effects as well that we talked about last week. So we can sometimes be tricked by early successes in treatment, which are not lasting. And I think they call that in research the decline effect, where often the enthusiasm that's involved with presenting new research tends to present more favorable results. Whereas with latter studies of the same thing, the success of the results can sometimes decline, especially if it's more of an independent study rather than the person who has presented something new. And I think that can happen with treatment as well. We can get some early successes, which then start to not go the other way, but plateau off a little bit. The cost. The average compensation cost in the UK is about this much. And this is what I was taught a lot at university, is, the legal side of it and the cost. And, I remember being, people trying to scare me when I was a junior physio to say, oh, you've got to really detect, look out for this Cauda equina because the compensations are huge. And it's all about this legality of it. And I never really got that. And I still don't, because for us as therapists, it's all about the person and the individual. And the reason that I want to know about Cauda equina, and the reason that I ask the questions, and the reason that I ask those difficult questions with patients, and the reason I ask them again at subsequent sessions, is because of the ability that we have to detect the early signs and symptoms, to detect those subtleties as well, and because of the significant impact that such an issue can potentially have on our patients' lives and on their quality of life. I don't sit there worrying about the compensations. I sit there worrying about my patients and their well-being. And that's always been my motivation for detecting red flags, which I think is just a very normal thing for all therapists.
Yeah.
So the classics, these are the things you see on assessment sheets and in standard education, and they're correct. They're 100% correct. But this is just to show you that the symptoms are not clear cut. It's not like detecting a fracture. So of these classics, bilateral sciatica, lower limb weakness, saddle anesthesia, and sphincter disturbance, in a study which I've referenced there, only 19% of patients that had Cauda equina syndrome presented with this characteristic combination, which I thought was very interesting and just something to bear in mind. So you can ask those questions, and if the answer's no, then it's not a positive exclusion of Cauda equina. You still need to watch out for the other signs and symptoms that we've talked about. So before we take some questions, just in conclusion, I'd written this, and I'd written a few notes down here. Just have a quick look. Other presentations. Oh yes, saddle anesthesia, bladder and bowel disturbances. Of patients that had Cauda equina syndrome, only about 40 to 50% had saddle anesthesia of confirmed cases. So if you had 100 people that had definite Cauda equina syndrome, roughly half of them would say that they had saddle anesthesia. So these questions that we ask are not that sensitive and not that reliable. And it's really about seeing if they have any of these symptoms or any groups of symptoms, rather than asking a question, getting the answer being no, and then concluding that it's obviously not Cauda equina syndrome. You can't, they're just not that precise and not that reliable. The only way to truly rule out Cauda equina syndrome is with an MRI scan. That's the only way to rule it out. There's no magic collection of questions, the MRI scan, and that's why there's such a low threshold for onward referral. What was also interesting is that sexual function disturbance seems to be one of those early signs. And I guess it's something that people often don't talk about, or even, as Mike said, ask about that routinely. I think physios, maybe half of physios ask it when they did some research, and even less of medics ask that question, but it can be an early sign. And of course, catching this early is key. So asking those questions might need to happen more frequently in my clinic as well. So it's just about framing them as well, isn't it? So yeah, after back, so bladder issues as well is also one of the most sensitive signs. Rather than sphincter tone, which is definitely a question worth asking, but bladder is also one of those most sensitive signs to look out for as well. But there's also some red herrings. One of the classic ones is constipation. Any bladder or bowel disturbances? I often ask the patient that, and they'll say yes, they do. They have some constipation, and that's not really a Cauda Equina issue, but you may wish to ask more about bladder and bowel disturbances, which they may have some other information that's more applicable. But constipation is usually, in my experience, linked to ibuprofen, taking too much ibuprofen, or just taking ibuprofen for a prolonged period of time. So in conclusion, detecting this can be difficult, or just is difficult really. So if you do suspect anything, then refer them to an emergency department straight away with a note of what the symptoms are, so the patient can relay that information. If they present to A&E and say their back hurts, they might not get the attention that they deserve. But if they present to A&E and say that they've got some numbness around their inner groin area and they've lost a bit of tone here, which you've written down for them, then that's the key information that they'll be taking note of in A&E. The MRI scan needs to happen within a few hours, not tomorrow or not after you've been on holiday, as a delay can lead to irreversible damage. It is rare, but if it's there, it needs to be tackled straight away. And MRI scans, has anyone had to wait for an MRI scan, they know it can take a long time. However, in the UK, the local MRI scanning department needs to have the ability to offer MRI scans 24 hours a day for emergency scans, and that's for scans such as this. The MRI scanning team may not be too happy, but that's not your problem or the patient's problem. The 24-hour access should be there. It is very rare, but it should be a core part of our lower back assessment. A core part. So if you've got any pre-made assessment sheets, then make sure you put down some notes on Cauda Equina there. And I do encourage people to refer to and use that card. As Mike mentioned, communicate the importance of questions and symptoms, and safety net the patient as well, so they have the information to deal with it and to present themselves to emergency department if they have these symptoms arise outside of your consultation. We didn't really talk about this much tonight, but do document your questions that you've asked, do document your patient responses, and do document your actions taken as well. And keep your assessments going over subsequent treatment sessions as well. And if you don't think you've quite got the assessment right, it needs to be timely, but you can still, you may have seen a patient an hour ago and you may have thought, you know what, I really should have said to that patient, or they had these symptoms, or maybe I should ask. Don't feel bad about phoning a patient up and saying, look, I've just reviewed your notes. Based on this, I think you should, present A&E with these symptoms. Or you may phone a patient up and say, you said when you came in about, a bit of sensation loss. I just want to ask you a few more questions about that. So don't be afraid to do that, not just for your peace of mind, but for the patient's well-being as well. So that's just one tip that I would give. Okay, right. Thanks, guys. Is there any questions on what we've talked about tonight?
See a good comment by Suzanne there about having an online form, worth putting the questions on the form, like you suggested, having them there as standard on your assessment form, and we do the same. We have an online assessment that we do before they come in, and with the way we're going to reopen now with the COVID situation, we're going to have to triage people anyway. So it's good to have these kind of things on a question sheet before they come in. All of the COVID stuff definitely on there, but then this as well if they have back pain. So
yeah, that's an interesting point regarding the COVID. There was a document that came out for people who were doing assessments for back pain, and obviously in the COVID situation, there's things are not available, like you can't go and have a hip replacement, or certain spinal operations or procedures are not available. But if a patient does present with Cauda Equina Syndrome, then they need to go and have this emergency scan, whether there's a COVID crisis or not. It's something which takes priority as well.
Definitely, yeah. Yeah, Melanie, we will upload the video, don't worry. So Dan will put it on the Physio channel, probably hopefully sometime tomorrow, or if not tomorrow, then definitely Wednesday. It's possible to have a webinar on some other systemic musculoskeletal dysfunctions. Of course, Tom. Which ones? Let us know.
Yeah, let us know, Tom.
Yeah,
Peter asked a question about how long does cauda equina develop. Well, if it's the trouble is with the true cauda equina compression is that if you get compression of the nerves, it's affecting the nerve's blood supply, and you can then start to get some permanent damage or permanent death of the nerve tissue, and that's why it's so important to work at this in a timely fashion.
Mm-hmm.
However, there are cases where the thing that's causing the compression is slow to progress, or where there's a kind of waxing and waning of symptoms as well. But if the compression is there and the actual symptoms of the compression are there, then it needs to be dealt with, dealt with quickly. So in answer to Peter's question, it really does vary. But
Mm-hmm.
if there's a compression in place, it needs to be dealt with quickly.
Brilliant. Cool. Great. Thanks, Dan. Thank you again. Yeah, if anybody has got any questions, we've just drop us a message on Instagram or Facebook or whatever. And we've got some more coming through. Should we do one more?
Yeah, it's about sexual dysfunction present in a female. Is it just numbness? Is there a classic female sign? Yeah, so I can answer that one. It is largely about sensation loss. I saw somebody posting the other day about pain on the inner wall of the vagina, but from my understanding, it's the sensation loss and loss of feeling, loss of ability to have pleasurable sensations, and also loss of ability to orgasm as well for females. So as you can imagine, they're very grown-up questions and might be a little bit difficult to ask in a clinical situation. However, just asking about sensation loss or changes around the genital region might lead to the identification of some problems, and there might lead to having to ask a few more questions about that if you need to. But to be fair, if they have some sensation loss around that region, then that's a red flag in itself. So you don't really need to delve with any further questions.
Then last one, I think, Dan. So Emma did ask a question ages ago. So just looking at the point of no return, do you feel that people are getting diagnosed quickly enough? And
oh yes, sorry Emma. Yeah,
rehab?
I did take your question. I hope that I would answer some elements of it. So are people getting diagnosed quickly enough? Yes and no. The whole focus of understanding Cauda Equina Syndrome better is because people need to be diagnosed early in order for there to be successful treatment. And that is the ongoing challenge, is that there are still people who are not diagnosed early enough, whereas looking back, they could have been diagnosed early enough. So without checking the literature, I would think that the large majority of patients are diagnosed early enough, but there's still a significant amount of patients who aren't diagnosed early enough. And that's why this Cauda Equina Syndrome is still at the front of our minds, still continues to be researched, and is still a popular webinar topic, is because we haven't quite cracked that problem yet. So I hope, Emma, that was your answer to the question. I think you had was there another element to the question though? Have you got the question there, Mike?
Saying about the rehab, I think.
Oh, the rehabilitation.
Yeah.
Are
they getting the right rehab? I guess that depends on the timeliness of the diagnosis. It's if they get diagnosed quick enough, then the procedure that they can have may never have symptoms again. Well, they're less likely to have symptoms again. But if it's left too late, then they could be in serious trouble and never recover.
Yeah, absolutely. Yeah.
Great. Thanks, Dan.
Thank you, Mike.
Everyone. Good questions again. Really good. So we'll see you next Monday at 8 o'clock. I'll see you next week, Dan.
Thanks. Cheers,
Take
guys.
care.
Bye, mate.
Cheers, guys. Bye.